So I think it's a couple of minutes after 7. I think we'll go ahead and get started. We've got a lot of people on Zoom already. So I'd like to begin by welcoming everybody to our third installation of Brain 101. It's been a lot of fun these last 2 weeks, and we've got, I think, a great session today as well. I'd like to remind you that this is hosted by Tami in the upper picture there, who's head of strategic development for the Department of Neurosurgery, also executive director of the Neuroscience Innovation Initiative, and by myself, I'm chair of the Department of Neurosurgery. Let me advance here. Oh, can't get it to advance. Oh, here we go. Sorry about that. Obviously, this is also sponsored by the University of Colorado Anschutz campus, and also by the Neuroscience Innovation Initiative. And I'd like to just take 2 seconds again to give a little plug about the Neuroscience Innovation Initiative. This is a program that started a couple of years ago, and basically the goals of the program were to strategically integrate the clinical and the research aspects of the neurosciences on this campus and across the state of Colorado, to foster collaboration between all of the researchers who are involved in neuroscience research, and then also to communicate the neuroscience research that's going on in the state of Colorado. And I think people would be surprised at how much is actually coming out of this state in the neurosciences. And this is really an initiative that hopefully will lead ultimately to a neuroscience institute in our state. We put together all of these groups. If you see in the lower right-hand corner, these are all the groups that are involved in neuroscience research. And there's really 7 program areas shown on the left-hand side. One of those program areas is neuro-oncology, and that's what we're going to be dealing with today. So our in this third installation, we're going to talk about the introduction to brain tumors and neuro-oncology. The first 2 sessions, first session was introduction to brain anatomy. Last week, we had some great lectures on stroke and also on traumatic brain injury. And Tami has recordings of both of those lectures, which I think she has sent out to the group, if that's correct. And today, all of these will be recorded, and this is the third of 6. I want to remind people that we leave time at the end of the presentations. We hope to leave about 10 minutes at the very end to answer questions, and sometimes that's the most fun part of the entire hour is answering some of the questions that people have. And we've had some incredibly good questions from these sessions. But how to do that is, if you look on your Zoom screen, there's a chat box at the very bottom shown by the arrow here. Anytime during the talks, go to the chat box, put in your question. Tami's going to be monitoring all of these questions, and at the end, she'll kind of select the various ones. We obviously can't get through all of the questions, but what we've done in the last 2 weeks is the questions that we don't answer, we go ahead and answer and then send them out to the entire group as an email. So please, register your questions when they come up. So having said that, we'll get going with our talk. This is the introduction to brain tumors and neuro-oncology, and we're privileged to have Dr. Denise Damek start this presentation. And Dr. Damek is a professor in the Department of Neurology. She's a Texan by birth, very proud Texan. Did her undergraduate and medical school at the University of Texas, and then went from warm weather to Rochester, Minnesota, to the Mayo Clinic to do her internship and her residency in neurology, and then did her neuro-oncology fellowship at the Massachusetts General Hospital in Boston. So Dr. Damek is one of the co-directors of the adult neuro-oncology program, incredibly knowledgeable on brain tumors, and she's going to start this overview. And then the second half of the talk will be myself. I'm chair of the Department of Neurosurgery, professor of the Augsbury Kent Professor of Neurosurgery, and have had an interest in surgical neuro-oncology for many, many years. I trained at the undergraduate at Cornell, trained at the University of Minnesota, and then residency in Michigan before coming here to Colorado. So with those introductions, I'm going to stop my share and Denise, let you take over.
Hello, everybody. I hope everybody can hear me okay. Thanks for the introduction, Dr. Lillehei. How do I advance? It's not advancing for me. Oh, there it goes. So no disclosures or conflicts of interest for this talk. So just an outline of what we're going to talk about in this first half is a little bit about what is cancer, some terminology, discuss some types of brain tumors, grading of brain tumors, a few statistics, and presenting symptoms. So cancer is basically a disease of uncontrolled cell division. Our brains, along with the rest of our body, are made up of countless living cells, and we have genes that manage or control normal cell growth, division, and ultimately death. And this process of cell regeneration is very rapid when we're young, and this allows us to grow. And as we get older, this really only occurs when to replace dying cells or to repair injuries. Cancer cell growth is different from normal cell growth in that it is not regulated and cannot be controlled by the normal checkpoints in the body that work on normal tissues. So for instance, in here, normal cells require a growth factor in order for the cells to divide. And in the absence of this growth factor, there would be no cell division. In cancer cells, it doesn't matter if there is a presence or absence of a growth factor, those cells are going to divide. Another thing that happens in cancer cells is that in a normal cell, if there's been unfixable damage to DNA, which is the building blocks of cells, the cell will be programmed to die in a process called apoptosis. In cancer cells, this doesn't happen, and the cell continues to divide, and it carries on that unfixable DNA damage to other cells. When we think about how cancer develops, we still really don't know exactly what is the trigger in that first cell that causes it to multiply out of control. Researchers are examining a number of factors that could contribute to this. There might be multiple insults or injuries to a cell from physical trauma, radiation, carcinogens. There might be a big single traumatic hit that damages the cell and causes the abnormality. A compromised immune system may play a role and allow mutated cells to continue to live and grow. Cell-to-cell communication, our cells communicate through various chemical signals, and it's possible that maybe something goes awry in that chemical signaling that can damage the cell's DNA. Are there any external risk factors that you could be exposed to that may contribute to forming a brain tumor? There's no risk factor that accounts for a large number of brain tumors that have been identified, and the only well-validated risk factor is exposure to ionizing radiation. So ionizing radiation is not the radiation that you get from just being outside and walking around, but this is going to be either therapeutic radiation, such as childhood cancer survivors that were treated with prophylactic brain radiation. They have an increased risk of both gliomas and meningiomas. Another very nice study that looked at this involved about 11,000 immigrants to Israel in the 1950s that had ringworm, which is highly contagious. It's also called Tinea capitis. And that was before we knew the dangers of radiation. And these folks were treated with radiation therapy for their tinnitus capitis. And they were followed for about 40 years and found to have an increased risk of glioma as well as meningioma, kind of in the same percentages as childhood cancer survivors that were treated with brain irradiation. We always think of atomic bomb as being a very high dose of radiation, but interestingly enough, when approximately 80,000 Japanese atomic bomb survivors were followed, there was no significant increase in brain tumors. Thyroid cancers were the one cancer that were seen at a significantly higher incidence. There is a little bit of familial risk. So if you have a family member that's first degree, so that is parents, children, or full siblings that have a brain tumor, then you have approximately twofold increase over the general population of getting a brain tumor. This isn't due to something that you inherited, and we don't really quite know what the mechanism of that is. A few definitions. So we talk in terms of primary or secondary brain tumors. Primary brain tumor is a tumor that starts in cells of the nervous system, the brain, the spinal cord. Brain tumors rarely spread outside of the central nervous system. A tumor that starts in another part of the body that spreads to the brain is called a secondary non-brain origin, also called a brain metastasis. And this is the most common kind of intracranial tumor. About 20 to 40% of cancer patients develop brain metastasis, the most common being lung. And we're not going to talk about secondary brain tumors for the rest of this talk. We're going to be concentrating on primary brain tumors. I don't expect you guys to be able to read this at all, but this is a list of all of the different types of tumors. There are more than 100 of them that have been identified through the definitive source of brain tumor classification, which is the World Health Organization classification system. Brain tumors are generally named by the cell of origin, and I'm going to take you through some examples of that. So this is a depiction of the meninges, which are the covering of the brain. So this is what holds all your spinal fluid in. There's multiple layers here. And if a tumor arises, generally from the dura, it's going to be called a meningioma. The most common primary brain tumor are going to be gliomas, and these arise from glial cells. So these include astrocytes, oligodendrocytes, and ependymal cells, and they give rise to tumors that are called astrocytomas, oligodendrogliomas, and ependymomas. So all of these glial cells as a whole give rise to a group of tumors, and all of these are under the umbrella of gliomas. Same thing, pituitary tumors generally give rise to pituitary adenomas. Pineal region, the pineal gland, give rise to pineal tumors. It comes up in clinic a lot in terms of what is a tumor? What is the difference between tumor, cancer, benign, malignant? So I'm going to take you through this a little bit so we can have some ideas of what these definitions are. So the definition of a tumor is an abnormal mass of cells in the body. Other terms can be neoplasm, lesion, space-occupying mass. A tumor can be benign or malignant, and generally something that is malignant is considered a cancer. So kind of like the analogy of all dogs have four legs, but not all four-legged animals are dogs. All brain cancers are tumors, but not all brain tumors are cancerous. In fact, only about 1/3 of brain tumors are cancerous. The rest are benign. So when we look at the difference between benign and malignant, benign are generally considered non-cancerous. These are often somewhat encapsulated tumors. They have a very slow growth rate. They generally press on the brain, but do not invade the substance of the brain. So the caveat of that is you can get a very nice surgical plane, and these tumors can be surgically cured. They have a potential to recur, but not very often. Malignant tumors, on the other hand, are cancer. These have a faster growth rate. These do invade into brain and other tissues. They may spread into other tissues. And in the nervous system, this is generally brain spreading into the spinal fluid or into other parts of the brain or spinal cord. These tumors generally do not spread into the body cavities, and malignant tumors generally recur. When we talk about cancer staging, what people are most familiar with is the T and M staging that applies to every other type of cancer. So people will say, oh, I have a stage 4 or a stage 2B. And all of that is based upon different criteria of size, infiltration of the tumor, whether it spread to lymph nodes, whether it has metastases. Well, brain tumors do not spread to lymph nodes. They do not metastasize outside of the nervous system. So we do not find this classification system useful. The WHO classification system basically assigns tumors on a grade of 1 through 4. Based upon clinical behavior, where 1 tend to be benign tumors, 2 through 4 are considered malignant tumors and have a, slower growing is a grade 2, a grade 4 is going to be your fastest growing, most aggressive. And here is an example of a schema for gliomas. So you have up top, you have the grade 1, 2, 3, 4. Grade 1s tend to be circumscribed. The example is pilocytic astrocytomas. These are very well circumscribed, separated from brain, can be surgically cured. Grade 2 through 4, which is what we generally see in adults, generally invade brain. And as you go from a 2, 3 to a 4, you have increased aggressive factors. So a grade 3, you're going to start seeing cell division. Grade 4, you're going to start seeing the tumor outgrow its blood supply. And generally, the prognosis decreases as you go higher up in grade. The latest brain tumor classification gets a little bit more complicated. So before, the tumor was graded only on the way cells looked under the microscope when the neuropathologist would look at them. The latest brain tumor classification basically started integrating molecular characteristics and mutations. So the caveat with this is you can have something that looks like a grade 2 or 3 glioma under the microscope, but if they have these particular genetic signatures, it doesn't matter what they look like under the microscope, they will be reclassified as a grade 4 tumor. Just to show you a different tumor, this is meningioma. The same thing. Grade 1s are going to be circumscribed, so non-infiltrating, doesn't invade the brain, can be surgically curable. Grade 2s and grade 3s are going to be more of infiltrating the tissues around it, more aggressive. And we also have some molecular characteristics that are involved in the diagnosis of these tumors as well. When we look at brain tumors in general, they're actually pretty darn rare. So brain tumors account for a little over 1% of all new cancer cases in the United States. As far as types of cancer, it ranks number 16. It's estimated this year that there will be roughly 25,000 people diagnosed with a brain tumor in the United States. However, brain tumors are the 9th leading cause of cancer deaths, with approximately 19,000 people projected to die from their brain tumor in 2024. This represents about 3% of all cancer deaths. So although brain tumors are rare, the effect of brain tumors on healthcare system is out of proportion to their incidence, mainly due to the high rates of mortality as well as the symptoms and the care that patients need from just having tumors in the brain. And this is kind of compounded by the fact that adequate treatment for malignant brain tumors involves access to multiple subspecialties, neurosurgeons, radiation oncologist, neuro-oncologist, kind of things. And if you want to kind of compare, I said that brain metastasis earlier were much more common. So in the United States, in 2024, it's estimated to have anywhere from 100,000 to 170,000 cases of brain metastasis diagnosed. So you can tell just the difference in range there. If we look at what percentage of tumors are malignant versus non-malignant, non-malignant brain tumors are twice as common as malignant brain tumors. The most common malignant brain tumor is going to be the grade 4 or glioblastoma. The most common non-malignant tumor is going to be a meningioma, and the second most common and following that's going to be pituitary tumors. If we look at prevalence, so what prevalence is an estimate of the total number of individuals that are alive with a disease in a population. So it's not looking at new cases per year. We're looking at how many people are alive with this diagnosis. So when you look at brain tumors compared to other cancers, they're the fifth most prevalent cancer, with approximately 1.3 million brain tumor patients alive in the United States in 2019, which was the last time this data was collected. Most of these are alive with benign tumors. Most of them are meningiomas, and only a tenth of this number are your gliomas. If we look at how many people survive 5 years or more after being diagnosed with a brain tumor, if we look at just only malignant brain tumors, that 5-year survival rate is about 36%. If we kind of break this down into only non-malignant brain tumors, so benign brain tumors, that's about 92%. And if we look at this for gliomas, as we go up in grades, grade 1, 95% 5-year survival, grade 2, 40 to 50%, grade 3, 25 to 30, grade 4, 5 to 10%. If we look at things over the years, this goes from 1975, and then the data cuts off because COVID just really kind of messed up with the data, so they're very far behind as far as collecting it. But you see a progressive increase in 5-year survival rate, which reflects doing better with malignant tumors, because you're not going to, when you have a 92% survival for benign tumors, that's not going to make too much of a difference improving that. So we are doing better, but we would like to do much better. When we look at presenting symptoms for brain tumors, kind of how do brain tumors cause problems? Well, a brain tumor can grow, and it can push up along normal brain. It can invade normal brain, and it can cause swelling around it of the normal brain. And when we think of the problems that are caused, we can divide these into generalized or focal symptoms. Generalized symptoms are generally caused by just mass effect, increased intracranial pressure, or kind of global dysfunction of the brain. These symptoms typically provide clues that something's not right neurologically, but it's not helpful in determining where that might be, where the problem may be in the brain. These symptoms generally are headache, memory, cognitive dysfunction, seizures, personality changes, nausea, and vomiting. Nausea and vomiting rarely occurs on its own. It generally occurs in the setting of a headache. The classic headache would be a headache that comes, doesn't go away, gets worse with laying down, so it's worse in the morning, associated with nausea, vomiting, and neurological symptoms. The memory loss can be all over the place. Sometimes it can happen dramatically and be the presentation. So somebody might have just can't work. They stop paying their bills. It may be something that's only recognized when a doc starts asking questions about, have you noticed any of these things? Seizures generally occur with lower grade tumors, but can occur with any type of tumor. And often if these are very mild focal seizures, people will say, oh, that's kind of weird, and not think twice about it until it starts happening more frequently. And sometimes they don't recognize those as seizures at all until somebody kind of asks them about them. Personality changes tend to be more being dulled down. So people may be put on antidepressants. They may be diagnosed with attention deficit and then ultimately have more symptoms that leads to the diagnosis. I want to just say a little bit more about headache because headaches are so common in the general population. And I don't want anybody going home going, I have a headache. Oh my gosh, I have a brain tumor. So headaches are just common. They're very common in brain tumor patients, but they're very nonspecific and they often resemble these tension type headaches. And it's more the intractability, the progressive intensity, and the development of focal symptoms that kind of cause concern. So if you get a headache, don't be too concerned. It's a headache that's problematic that comes with other things that's worrisome. Focal presentations are non-diagnostic for brain tumors, but generally tell you where things happen in the brain. So this graph here basically just outlines where in the brain malignant brain tumors occur. And so if you remember from Dr. Ogerman's lecture, he talked about different parts of the brain controlling different things. Well, when we look at the distribution of malignant brain tumors in the brain, it really kind of distributes based upon the volume of that. So the frontal lobes, the temporal lobes, the parietal lobes are where most of these malignant brain tumors are going to occur. This other brain is going to be overlapping sites. And most of these brain tumors are going to happen in what we call the supratentorium, or the top area of the brain, not the cerebellum or the brainstem. And the symptoms that we generally see, so if things happens in the motor, in the frontal area, in the motor strip, you're going to get weakness on one side of the body. Language tends to be more word finding problems. The sensory things are not like the pins and needles, burny pain that you see on the diabetic neuropathy commercials. This is going to be more loss of sensation, kind of loss of awareness where your limb is in space. The vision problems in the occipital cortex are generally going to be loss of a field of vision on one side. And if a tumor involves the cerebellum, you can get gait imbalance and incoordination. Brain tumors may be asymptomatic. So Colorado is a very active state. And with a lot of sports and outdoor activities, you get head injuries. And so people get a lot of brain scans, and we see sometimes incidental findings of brain tumors on a scan. So now that we've kind of talked about what symptom may lead to an emergency room or a doctor visit with these brain tumors, I'm going to pass it on to Dr. Lillehei so he can talk about diagnosis and treatment.
Okay. Can you see my screen okay? Yeah, okay. Well, thank you, Dr. Damek. One of the things that kind of occurred to me as she was talking, we've kind of designed this program to be targeted towards the first year medical students. And one of the phenomenon of going to medical school, at least in that first year, was every lecture that you had, you left the lecture theater thinking that you had that tumor or you had that disease. So as hearing the headaches, I think I thought I had a brain tumor for the whole first year of medical school. So not an uncommon phenomenon. So what I'm going to talk about is the diagnosis. There's going to be some overlap here, so I think that will be good. I'm going to talk about treatment, and I'm picking just 3 of the most common tumors that we deal with: meningiomas, pituitary adenomas, and glioblastomas. Far too many to discuss the whole spectrum of these tumors, and then talk just a little bit at the end about prognosis and survivorship. So, diagnosis. Well, for brain tumors, it's really developing a high degree of suspicion. And that degree of suspicion for us as clinicians really arises from listening to the patient. Very, very often, the neurologic exam in our patients is normal, but their symptoms are slowly progressive. It's not uncommon for patients to have visited their primary care doc 1 or 2 or 3 times, and then ultimately end up in an emergency room where they have a CT scan done, or the patient themselves say, "Look, I want an MRI scan," and demand an MRI scan, and in fact find a tumor. So developing that high degree of suspicion is really the first thing in diagnosing a brain tumor. The actual studies that we use to diagnose are really CT scan or an MRI scan. A CT scan is based on X-rays. An MRI scan is based on magnetic waves, and they have different properties. Then, depending on what you see on the CT or MRI, it may be definitive to lead to a surgery, or it may still not be clear, and the patient may require a small needle biopsy of the lesion to make the diagnosis. So just to give an idea of a scan, this is a CT scan in your upper left-hand corner, and it's actually a pretty informative CT scan, more so than usual. CTs are very good, and I'm going to put on a little bit of a laser pointer here. So the skull is bright white because it has a lot of calcium. So calcium is very bright on a CT scan. Water, pure water, this is water in the ventricles, is completely black. So over here in the this is the right side, the posterior frontal lobe. We see an abnormality that's very bright. This was bright before contrast. After contrast, it was bright, but you see the black sort of surrounding to that, and that's black because there's an increased water content. And as Dr. Damek said, a lot of these tumors will cause edema, will cause swelling. Swelling is just water percolating into the substance of the brain. And this is the edema because of this lesion. Well, shown in the middle picture, using stereotactic guidance, we were able to open a little bone flap over the lesion. The dura here is peeled back, and the dura, by the way, is where the meningiomas occur. But underneath, you see the surface of the brain here, and you see the pia, which has all the blood vessels. And underneath the pia is this pigmented lesion sitting right in the brain, and here it is resecting, and this turned out to be a melanoma. So the patient obviously didn't have the diagnosis of melanoma at that point, but this was a metastatic melanoma, which very commonly goes to the brain. Here is an MRI scan to kind of show the difference. In the upper left-hand corner is a CT scan of the same patient. Now you don't see anything very specific, except both MRs and CTs, the brain should be very symmetric. One side should look like the other side. Well, if you look at this posterior, it's a little bit darker on your right-hand side, but it's the patient's left hemisphere. So there's something going on there, and you get an MRI scan, and it's much more informative. You can see multiple lesions in the brain at that same level. And if you look a little bit lower on the MRI scan, you see multiple other lesions. And this was metastatic testicular cancer in a young man, which is very responsive, actually, to radiation and chemotherapy. So the MRI is much, much better at looking at the brain substance, the parenchyma of the brain. The CT scan is very good as a screening exercise, or it's very good at looking at blood in the brain for trauma. So we tend to use CT scans for trauma. We tend to use MRI scans if we're trying to diagnose brain tumors. So what's the treatment options for brain tumors? Surgery, as Dr. Damek talked about, surgery may be the only treatment you need for a benign brain tumor. For the more malignant or aggressive tumors, you may combine that then with radiation therapy and chemotherapy. We're now in the new era of doing analyzing genetic mutations in the tumor tissue, and that leads to what's called targeted therapy, where you can actually target some of these abnormal gene mutations and get a little bit away from chemotherapy into more what we call biologics that target. And then immunotherapy I've included here. That's really in its infancy at this point. It's much more useful in some of our other tumors outside of the brain. in the brain itself, it's getting there, but it's not there yet. So what's the distribution of all primary brain tumors? You've seen this slide from Dr. Damek. This is just a little bit different, but meningiomas, most common, a benign tumor. Glioblastomas, unfortunately, also very common, probably the most malignant tumor that we deal with in the brain. And then pituitary tumors make up a smattering of that as well. So going into treatment, here's a meningioma. The meningiomas are not really tumors of the brain themselves, but they're the tumors of the coverings of the brain. And so they arise from the dura, either over what's called the convexity here, or there's a membrane that separates the two hemispheres of the brain called the falx. And tumors can arise from the falx. They can arise from the choroid plexus, which is inside the ventricle. And then shown here on a side view of the head, you can get them along the skull base, the base of the brain. Up above, you can get it over the cerebellum and even down into the brainstem. Meningiomas of the spinal cord are not totally uncommon. So here's a picture in the lower left of a patient that we're going to talk about. He presented with about a 12-month history of progressive difficulties with his left leg. This is on the right side. It's up at the very top of the brain. It turns out it's right in the motor cortex. So before we get to him, this is just a netter who's an artist, a medical artist, showing a meningioma being taken out of the brain up above. Tends not to invade the brain, so came out fairly nicely. This sort of tumor shown below would be a difficult tumor to resect because it's a meningioma, it's a benign tumor, but it's really pretty embedded into the brain tissue itself, but surgery is still the treatment. So this patient I just talked about, here's his tumor. Well, his tumor is sitting right up here at the top, right along the motor strip. The red here is the motor strip. Behind the motor strip is the sensory cortex. So it's sitting on its right side, and the motor cortex on the right controls motor function on the left side of the body. So it's his left leg that was becoming weak. And if you think about where that tumor is, and then you look down here to the homunculus, well, it's sitting right here in that inner hemispheric area, so right around the hip and foot region. So it makes sense anatomically to the tumor and his symptoms. Here it is shown from the side. Looks like it has very nice discrete borders, which meningiomas tend to have. This is an axial scan. There's a significant amount of edema that's associated with this tumor. On the left here is a axial view, but on the right is a coronal. And the tumor itself, this is before contrast. So it's sitting right up here. You can't see the tumor too well, but it's generating all of that edema into the brain, which does create more symptoms. Here he is. This is taken 24 hours post-op. Here the tumor's been taken out. You see artifact up here from the staples in the skin, and then a little bit of a hole where the tumor was. It took him about 4 to 6 months to recover strength in that left leg, but ultimately he did have a full recovery. So pituitary tumors, particular interest of mine. The pituitary tumors, Dr. Damek showed, obviously arise from the pituitary gland. They can come in many different flavors. They can be non-secreting, basically not secrete any hormones at all, or they can secrete individual hormones like ACTH, which drives the adrenal gland and causes Cushing's disease. You can get growth hormone secreting tumors that cause acromegaly or gigantism. But by far and away, the most common is the non-secretors. Here's a picture of a patient of ours, Leonid. Leonid is in the Ukraine. At the time, he was the tallest man in the world, 8'5" tall, lived in a little village in the Ukraine and was relatively shy. Unfortunately, Leonid has passed away from bleeding from his tumor into the brain. But this is us visiting him at his house in the Ukraine. So the ACTH secreting tumors, here's the pituitary gland. It secretes all these different hormones that really control function throughout the body. It's important for breast milk formation and pregnancy, for the adrenal gland, for the thyroid, for bone growth, the control of the ovaries and testes. It even secretes hormones that allow you to concentrate urine in the kidneys. But Cushing's disease, with too much cortisol, it wreaks havoc on the body with diabetes, high blood pressure, obesity, muscle weakness. You get calcium that goes out of the bones. You get frequent fractures in the rest. So it's all due to a little tiny tumor sitting in the pituitary. The pituitary gland sits down below here, so we're able to actually operate on the pituitary gland by going transnasally through the nose and take these tumors out. And they tend to be little tiny tumors, causing all of those symptoms. And let's see here. Here's looking through the microscope at a pituitary gland. Now, that pituitary gland is only 12 millimeters from side to side, and the tumor is hidden somewhere in that pituitary gland. So as we're looking down through the microscope, coming up through a transnasal route, we're searching for that tumor and gradually kind of freeing the pituitary away from its adherence to the dura and kind of pulling it up and looking at all the sides. In this particular patient, the MRI scan was normal, but we knew there's the tumor sitting over there on the right-hand side. And you can see it. Here's that curette is only 2 millimeters in diameter, and taking that tumor out, that's showing the tumor there. And then now there's the resection. Here's our cavity that's left behind. And this is the patient. Here she is on the left before operation, and on the right, this is 2 years later, and I guarantee you that's the same person. So Cushing's can be very dramatic in the symptoms that it causes, and if it's untreated, patients rarely survive more than 10 to 15 years. Treated, your lifespan goes back to normal. So finally, talking about gliomas, Dr. Damek talked about the different glial cells in the brain. There's astrocytes, there's oligodendrocytes, there's ependymal cells. Well, it's the astrocytes that lead to this glioblastoma, the grade 4 tumor, which has been the toughest tumor for us to treat. Shown in this cartoon, a meningioma just kind of pushes the brain away. Schwannomas, pituitary tumors, they push the brain away. They don't do any invasion, whereas the gliomas tend to invade the brain. So even with surgery, you can take out what you think is the mass, but there's always some tumor cells left behind. So surgery is not curative. It's helpful for diagnosis and it's helpful for mass effect, but it's not curative. This is a cross-section of a glioblastoma, and you can see just how ugly these tumors are. This is in the left temporal parietal region. So just to kind of drive home again some of the statistics that Dr. Damek showed for a pilocytic astrocytoma, shown right here, survival at 10 years is 83%. That's a benign, that's a grade 1 tumor. As we work up to the grade 2 tumors, 10-year survival, 42%, the grade 3, 19%, but the glioblastomas, the 10-year survival is less than 2%. 5-year survival, maybe 2 to 3%. So it's a very, very tough. And this is with aggressive treatment. This is with surgery, radiation, and chemotherapy. What's the treatment for the glioblastoma? It's maximum surgical resection, followed by radiation therapy, followed by chemotherapy. And right now, temozolomide is the drug of choice. And recently, FDA approved the use of electromagnetic radiation. So these are electrical fields that a patient will wear like a shower cap, and it will deliver electric fields, and it's shown to be beneficial. So how do we operate on these higher grade tumors? Obviously through a craniotomy. We expose the brain tissue. This is the brain tissue shown on the right. The problem with these tumors is the brain tissue doesn't look too much different than normal brain tissue. So how do you get a resection, knowing where your margins are? The way that we do that is we use guidance. This is computer guidance that we actually have a wand that's been programmed to the MRI scan, telling us where we are at any point in the brain. Here, this is the tumor. You can see this patient was actually done awake so that we could stimulate the cortex and make sure that we don't take any motor area. Here's the tumor, the MRI scan of the tumor pre-op, and here we are post-op. And that allows us to get as an aggressive resection as we can. The one other way that we can get a better resection is with the use of a drug called fluorescein. And fluorescein is just injected intravenously into the brain. And then we have a special filter on the microscope, and that fluorescein actually lights the tumor up. So you can see the glow of the tumor and the relatively normal brain around it. And we use that as a margin under the microscope. Over to the right, that's the dura. The dura doesn't have a blood-brain barrier, so it's always enhancing. But the brain itself, the normal brain has a very tight blood-brain barrier, and the fluorescein goes right through it. And that allows us to get a more aggressive resection, as shown here. So I'm going to end with this. This was a 36-year-old female, now over 25 years ago, who went to DIA, probably was Old Stapleton, no, I think it was DIA, but went to the airport to pick up her family. They were visiting from out of state, got confused and was wandering around the airport, and the family actually found her at that point and said, you know, something is not right. She was 36 years old at the time and had this MRI scan that shows a very large, kind of ugly looking right frontal tumor. She underwent surgery. This is a scan of hers 7 years out from surgery. I'm going to show an interview here of her 15 years out from surgery, and she's past the 22-year mark at this point. So I apologize that this is a little bit like an advertisement, and I apologize for that part, but I want you to concentrate on really what she is saying.
I first found out about the cancer when I went to an emergent care, and they thought it was a sinus infection. And when the sinus infection didn't get any better, they sent me for an MRI.
As the neurosurgeon, it's really my role to sit down with the family and discuss what the diagnosis is.
He said it was a tumor about the size of a $50 in my right frontal lobe.
It's unusual, unfortunately, for patients to get beyond 2 years. Mary is very aware of what her survival should have been, but she also has taken a very positive role in this disease.
My son was just a year old, and my two girls were 6 and 8. I was not gonna, lay down and die before and leave my kids at that age, or even in a year or two. I was gonna make sure that I was around.
What sets the University of Colorado Hospital apart in the treatment of brain tumors is that we've assembled a very dedicated group of physicians. Our goal is to try to beat this disease.
I have a friend who's a nurse, and when she tells other nurses that I survived it, they don't believe it. It's a pretty amazing thing that I survived, and I'm very glad.
She is one of a handful in the country that has survived 15 years with this diagnosis. It's just been unbelievably exciting.
The region's only academic medical center, University of Colorado Hospital. All things possible.
Okay, thank you. And I'll stop my share here. And I think we have, we're right on time. So Tami, I think we have time for questions.
Okay, we have quite a few actually. Let's start with the last and move backward or whatever. Are all patients awake during these brain surgeries?
Yeah, I'll take that question. The reason for doing a patient awake is if the tumor is in an area, what's called an eloquent area of the brain. If the tumor is near the motor strip, if the tumor is near the speech cortex, then we like to do them awake so that we can actually stimulate those areas and stay away from them. If the tumor is in a more silent area of the brain, we do it asleep. So So probably 25% of our cases are done with patients awake and 75% with patients asleep.
We had a question yesterday from a donor that was here asking if during those awake procedures, if the patients ever have any recurring trauma from remembering that.
Yes. The majority do very well, but some patients it is not an enjoyable experience. So I have to be totally honest, and sometimes it really can be tough. And we've had instances where we've gone ahead and put the patient asleep and finished the surgery. Most of the time, though, it's pretty well tolerated.
Okay, what are the chances of these tumors coming back to the same area? And they're not distinguishing which ones, but could be either.
Denise, I'll let you answer that then.
So roughly 80% of tumors will recur at the original site, and about 15 to 20% can occur at other areas of the brain.
These are gliomas.
Gliomas, as well as most meningiomas. I would probably increase that. Probably 95 to 99% of meningiomas will recur at the original site.
Okay. Do you use the gamma knife procedure, and how does that differ from radiation?
Yeah, so gamma knife is a form of radiation, and instead of using photons, which is what your regular radiation is it uses gamma particles, and it's a very focused type of radiation therapy that's very valuable for well-defined tumors. So it's great for residual meningiomas that you can't get at all, or acoustic neuromas. Even some pituitary tumors, people will use it in. So it's very focused. For a glioma, as we talked about, there's tumor cells in a glioma that go beyond what we can see. So you really don't want to use focused radiation. You want to use a more broad radiation. So the gamma knife is not useful for high-grade gliomas. It's useful for more of to be honest, the benign tumors that misbehave.
Okay.
Is that fair, Denise?
This is a little complicated, so I'm trying to decipher, but I think what it's asking is, how do you decide between treatment versus the side effects of radiation and chemotherapy? What factors influence your choices of treatment?
So I think a lot of the factors is the how symptomatic the patient is. Is there visible, measurable tumor left behind after maximal surgery, as well as the overall prognosis. So there are some tumors that the aggressive, grade 4 gliomas, the glioblastomas, we always recommend radiation and chemotherapy. But for a grade 2 astrocytoma, if you get a gross total resection, then the recurrence rate is there, but it's very low for a long period of time. And so we will often just observe patients with scans and then trigger treatment if they get a symptom or recurrence on their imaging, because early radiation and chemotherapy might be associated with down the line side effects. Does that kind of answer it? I'm not certain.
It's a difficult one to answer, I think. But yeah, I think that answered it. Now, this is not a question, but this is a shout out to Dr. Lillehei, who removed my tumor almost 3 years ago, and I am still cancer-free, living a normal life in my late 20s. I can't thank you enough. And that's from Seth. And then there's some other comments here too that I'll try to save for you both later about people you've saved and how long people have lasted and things like that. Do you use or look into using segmented models of the tumors from CT MRI scans to plan your operations? Or do you just eyeball the scans with 3D modeling? How long is the planning process in a surgery?
Yeah, I can kind of, so what we do now in surgery has changed a lot, obviously, since I started in this. And we basically use computer guidance for almost all of our surgeries. And that's where the MRI scan is loaded onto a software program. The patient is brought into the operating room and their head is stabilized into a pin system because it can't move. And you're able to then register the head in three-dimensional space, and then that registers with your software. So virtually everything we do is with guidance. So we are able to use either the microscope or a wand and tell exactly where we are in the brain. So yes, we do. And then there's fancier things now that we do functional MRI scans to identify exactly where the motor cortex is, where exactly speech is. And some of the spectroscopy looking, tractography looking for the different tracks in the brain. So it's gotten very sophisticated, our approaches. For glioblastomas, it's improved our resection, but it's still very much dependent on our neuro-oncology colleagues after surgery because there's still tumor cells there.
Is there any difference in the pattern or type of seizure from a brain tumor versus a seizure from some other metabolic or infectious disease?
So
Good question.
because brain tumors tend to be, if a seizure is being caused by kind of a lot of mass effect just in general in the brain, then seizures tend to be very similar to, an infection, encephalitis. But if the seizure is being caused by a very focal part of the tumor irritating the cortex, then they tend to be focal seizures. So not your generalized or grand mal seizure, but more of, an odd taste, deja vu, twitching of one side of the body, type of thing.
Okay. How much does a patient suffer through the treatment of a glial tumor?
I can answer. I'll start out, and maybe compared to other types of at least radiation and chemotherapy, treatment of brain tumors is relatively easy in the sense that the drugs we use right now are very well tolerated compared to what you get for breast cancer or lung cancer, sort of thing. So in that respect, is it fair to say that Denise, the treatment's a little bit easier?
I think it is. I mean, I would answer that question probably in terms of if an individual after surgical resection doesn't have neurological problems that would cause them not to work, then they generally are able to work through the radiation and the course of chemotherapy. So they generally are a little bit tired at the end of the day, end of the week. But and some people are more just power through than others. But that could be a basis of, you can kind of power through and get through, whereas some treatments for some cancers like breast cancer, those folks generally have too many side effects to reasonably think about working during therapy.
And it isn't because temozolomide is relatively mild as far as its side effects, and it isn't because we wanted it to be. It just so happens it works best on brain tumors.
We got lucky.
Yeah.
And this is added on to that question, that they knew somebody that had a melanoma brain tumor that was treated after surgery with immunotherapy. The patient did very well. And how often is this done at CU?
Yeah, the CU has a very active and large melanoma clinic. Colorado, because of our high elevation, we get a lot of radiation from the sun. So melanoma is actually fairly common in Colorado. Melanoma is one of the types of tumors that is very, what we call antigenic. It's very recognizable by the immune system. So immune therapies, it's one of the better tumors to treat with immune therapy. Unfortunately, gliomas aren't that antigenic. So immune therapy doesn't work nearly as well.
I think we're about out of time, although we do have a few more questions, and I'll get the answers to those and send them out to everyone.
Great. Well, thank you everybody for attending. We'll be back here again next Tuesday, 7 o'clock. And our next session, I think, is on depression, Alzheimer's.
It's on Alzheimer's, yeah.
Alzheimer's and degenerative disease.
With Hunt Potter and Peter Pressman.
Great. Well, thank you all.
Take care. Bye.
Bye-bye.